Thank you so much for inviting me. It's wonderful to be here, and particularly amongst so many people who are working every day on our mission, which is really to use health information technology to improve health and healthcare. It's not about the technology, it's more about the improving health and healthcare. And really it is always about people doing that. I want to review today a sense of how far we've come in the past 2 years, but stop and ask the question, what's it all for? What's the technology for, and where's the future looking in that respect? And then ask, I guess, the follow-on question of, okay, but what does it all mean for patients? And then there'll be the turn when I ask you for something. So in terms of how far we've come, let's take a look at two things, adoption and exchange. So 2009, when the HITECH Act was passed, after, I don't know, decades of availability of electronic health records, the rate of adoption in the US among primary care providers stood at roughly 20%. 20 years, 20%. Within 1 year, between 2009 and 2010, that jumped to 30%. This year, I think it'll be 40%. Next year, maybe 50%. And then it will have tipped. The way, I think in Cincinnati, it may have already tipped, where it's increasingly assumed to be a part of delivering good care that you would have an electronic health record. But we knew that it was going to be hard work, particularly for some of those small practices and primary care providers who don't have the resources for the upfront funding or the technical assistance or the know-how or the time to do this. So, in the introduction, they mentioned the work that we did in New York City between 2007 and 2009, getting 1,500 providers up on electronic health records, and it sounded good at the time, but now extension centers are doing that all over the country, right here. You're going to be surpassing that, what seemed to be great accomplishment 2 or 3 years ago. We now have 62 extension centers doing this hard work every day with the practices, with federally qualified health centers, with rural health clinics, with critical access hospitals, with primary care providers and small practices. The Tri-State REC has received $10 million of funding to help be able to provide that heavily subsidized technical assistance that can unlock $75 million or more in the HIT incentive payments. You now have, as I heard, over almost 1,100 primary care providers signed up, hundreds of whom are already at stage in live on electronic health records, e-prescribing with quality measure reporting. And a large part of this, success of this, is going to be on the Medicaid side, where the upfront funds are more available, where you don't have to have demonstrated meaningful use before you get the payments, where there are not the penalties, and where people can go for many more years of getting incentive payments. And Kentucky led the nation in getting those incentive payments out there. And now we're proud to say that Indiana and Ohio have joined them. And Medicaid providers in all 3 states can qualify for those incentive payments. Of course, it's also a workforce issue. So we created a community college program. And Cincinnati State is participating in that program of training the health IT workforce. We have people who spent 15 years, for example, in the auto industry on IT, who've now been retrained and are helping family practice docs and fairly qualified health centers adopt electronic health records. It's also, though, about exchange. So it's not enough to have electronic health records in the practice. You also need to be able to exchange the information. HealthBridge clearly is one of the leaders in the country in this. 28 hospitals, over 5,500 physicians, 17 local health departments are connected. But HealthBridge is not matched throughout the country. We don't have, you're very fortunate to have such a resource available to you. So in the past 2 years, we recognized that we need to broaden the range of options available, not only because the technology isn't there, but also because the level of trust in many communities is not there to enable this sort of health information organization to survive and thrive. So we said, well, maybe we should have some protocols for more simple ways of exchanging information. If from point A to point B, we want to send information, 2 years ago, you had to negotiate every time. How do you want to get it? How should I send it? Should I FTP it? What security do we use? Where do I send it? And we said, this is crazy. We should have some simple ways of people to do simple things, like send a primary care doc to a referral, or emergency room to the ED doc, from the ED to the primary care doc, or from the primary care doc to public health. Not everywhere is going to have a HealthBridge. So why don't we create some generally accepted protocols for how to do this? Now here's the interesting part of the story, is how we did it. It's a new way, I think, for government action. We didn't say, let's let a contract to determine what the best protocols would be. We didn't impanel a committee to sit behind closed doors and then emerge with what the standard shall be and put it in regulations. What we did was we said, we're going to throw up a wiki, and we're going to open the door, and we're going to say whoever wants to participate can participate, but it's a duocracy. You get more clout the more you do, not by the size of your organization or your market cap. So we had Microsoft very actively engaged. We also had small companies like VisionShare that I'd frankly never heard of, and the American Association of Family Practitioners, and hospitals, and HIEs. And 3 different proposals were put forward. One group said we should do, I'm not going to get into the technicalities of it, but I'll just use the acronym. One group said, let's use IHE SOAP. The other group said, let's use REST. And the other group said, let's use SMTP. We said, we don't care. But we're going to do this for 90 days. You're going to build working models of this. Build it. It's a duocracy. Build it. We're going to do working models of this. But after 90 days, you're all going to agree on one. And after 90 days, they did, because they believed in the mission and the goal more than they believed in the rightness of their particular technical solution. Another 90 days, we had working implementation. Another 90 days, we had prototypes. And another 90 days, within a year of starting the project, we had 95% of the EHR marketplace, including many of the vendors, I think maybe all the vendors exhibiting here, saying, yeah, okay, seems pretty simple to do. We'll implement those protocols too. It's one more arrow in the quiver, but it solves a simple problem simply. And I think it's going to make a big difference in enabling the kinds of simpler flow of information for people who don't have access to the kinds of services that HealthBridge does. Now, by the way, HealthBridge also will be able to provide those same protocols. But now we get to the question of, okay, you have these health records in doctors' offices. Let's take that as a given. And okay, maybe now there's more information moving around or able to move around. So what? For what? And I liken this to having, pianos in doctors' offices. As long as they're sitting there, and we can do certification, we can ensure that when you push that button, it goes blink, 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 right? But what we need is to make music. So you need to, and what folks who've done this journey, like Dr. Mira, Dr. Callahan, and others, will tell you is, it takes a lot of work to go from having the piano to be able to play Chopin. And that's what they've done, is they've put the notes together into chords, and they're playing beautiful music with the tools that the adoption and exchange give them. How do we get to the transformed healthcare system? That's the title of our meeting today. I would say we do it the way It's happening here in Cincinnati. One, we set goals. That's really important. Just saying, you know what, there's a lot of worthy things we could focus on, but why don't we all agree on adult diabetes, reducing readmissions, improving quality of care, reducing the cost for care of patients, reducing the consequences of this, the deaths, the amputations. Let's just do one thing. Let's just focus. And the things we learn from doing that, focusing on that together, will then be applied to everything else. It could be applied to cancer screening and HIV and all the other rest of it. So let's start with goals. Here, with the HealthBridge Beacon, they chose adult diabetes and asthma in children. And I believe you're going to knock the hell out of it, because you're going to bring the focus to bear. You're going to bring the community to bear. But you're also going to have the other essential pieces. What are the other essential pieces to this? Technical assistance in doing that hard work, maybe the hardest piece of this all, which is change management, practice change, practice redesign, continuous quality improvement, lean, call it what you will. It's that process of thinking, we've always done it this way, but maybe we shouldn't. Maybe there are better ways of doing things. And I think for healthcare, it's changing the paradigm from the retail model. You know, I talk about the shoe store. You walk in a shoe store. If they're a good shoe store, they say, can I help you? And they give you good service while you're there. And you walk out, and that's it. That's a shoe store model delivery of healthcare. And all too long, we've been delivering healthcare that way. Patient comes in and we say, how can I help you? We can't do that anymore. We got to shift to a model of healthcare that sanctifies that relationship between providers and patients, that says we have a responsibility that goes beyond the time, the 0.001% time of their life when they walk into your office. The concept of population health management. So we have to provide that assistance for that change, and that's what the extension centers and the Beacon are doing. We have to liberate data and mobilize information. All of these, the lifeblood of this is information, better information for decision-making at the right time, information for patients, information for doctors, information for hospitals, information for patients. And that's really where the technology comes in. We also need to reward value and quality. For far too long, many of you here have had the reality that if you spent more time, because it takes more time, if you worked longer hours, if you worked harder and did all the right things and you saved that patient the admission, you reduced the complications, you got paid less. Or the system got paid less. The hospital got paid less. That doesn't make sense. And I think by all accounts, we're shifting to an era of accountable care, where you can be accountable for that care. Whether it's this ACO rule, another ACO rule, whether it's patient-centered medical homes, whether it's value-based purchasing, whether it's bundled payments, I don't care what it's going to be called, but the concept is going to be that it's not going to be just volume that gets rewarded, that there will be incentives for value. That much is clear. And finally, we engage the patients. So, I think as we get into this, what I hope will be a virtuous cycle where better information systems enable smarter payment, and smarter payment and the availability of those technical assistance resources enable the practice change, to implement the information systems that enable better payment, that enable better information systems, and we'll go round and around in a virtuous cycle, whereas before we've been in a vicious cycle. That's my hope. But we can't do it, we can't be patient-centered without the patient in the center. So let's talk about that. A few things. One, what does it mean to be patient-centered? Well, it means, first of all, that we have patient-centered design. When I had we were working very closely with a practice in New York City, and we were building all these decision support prompts and alerts and registry tools and so forth. And we got a national expert to come in and help us with the technical stuff. And he said, sorry, before we start, could we take a walk through so I can see what it's like from the perspective of the patient going through your clinic? That's patient-centered design. That's saying, let's not build the system around how, doctors, nurses, clerks, hospital administrators, government bureaucrats wish the system were. Let's build the system around what the patient experiences. That's part one. And let me tell you, in all the different tough governance stakeholder discussions you have, you're missing an opportunity if you don't bring it back to what's best for the patient at every possible opportunity. What's best for the patient here? I hear what you're saying about your organization. I hear what you're saying about whatever contract issues that we have between us. But let's just make sure we put on the table what's best for the patient here. I think is one. The second part of putting the patient in the center is literally saying, it's good to have all this back-end, business-to-business people talking to each other about the patient. But you know what? If the patient says, can you give me my data? That they deserve to have their information. And that they can then be the medium for doing what they want with it. And that there will then be all sorts of interesting stuff that the consumer e-health market, which in case you hadn't noticed, spins a lot faster than the clinical IT market does. That there will be all sorts of fun, interesting, crazy, wacko, new stuff that gets built for the consumer to be able to use their information to improve their health, to pay their bills, to interact with their doctor, to do gaming and social and lose weight together and do whatever other crazy stuff that they're going to do. But the first step is going to be us recognizing that they deserve to have their data. Do with what they will. And to us, make it easy for them to do that, not harder. And the third part of being patient-centered means putting the patient's interests in the center. And let me tell you, there are few patient interests higher than their privacy and security. So we have to share responsibility for that. There was recently a report released by the Inspector General of the United States, Health and Human Services, that said we're not doing enough to protect the security of patient information. They said we've done audits of these healthcare facilities, and what they found was unacceptable. And each of us has to look within our own organizations and say, ooh, do we ever put patient data on laptops that can get lost or stolen, or on thumb drives that are not encrypted? Ooh, do we ever not lock the door to where the data backup tapes are kept? Oh, wait a minute, do we ever use a general password for, administrator? Have we ever not, used WEP protection on our wireless instead of the newer standards? Have we ever done things that value convenience over security of the patient's information? That's unacceptable. It's against our professional obligations. It's against the patient's expectations. And it's against the law. So the HIPAA security rule says you're going to do all those things, that you're going to do an assessment of security in your practice. And in meaningful use said, you're not going to do an assessment, you're going to mitigate it, and you're going to test that you did that assessment and you mitigated any risks that were present. The Office of Civil Rights has a responsibility to investigate and enforce, and they can enforce heavy fines. And they started. My alma mater, Mass General, was one that got hit, first time ever, with heavy fines around violations of the HIPAA privacy and security rules. But yes, we have to make it easier to do the right thing. And that's what we're trying to do. We have to make it easier to have identity assurance for providers, where two-factor authentication isn't so difficult that it makes you say, I'll just tape this up to the monitor here. Not that any of you have ever done that. That we make it easier so that encryption just happens. Make it easier so that audit trails are invisible to us. And we need to give training and support, because it's change. It's changing the way we do things, and I think that's an important role for the extension centers. It's an important role for the professional societies, the associations, for all of us. So what am I asking of you? You knew it was going to come. To providers and hospitals, depending on where you are, each group, each provider, every hospital, every clinic has to make the decisions that's right for them, when it's right for them. But I would urge you to start. Just start. Make the change. If you're still on paper, if you're a primary care provider, you're a rural health clinic, you're a federally qualified health center, you're in an underserved area, you're a critical access hospital, call your extension center. They're there to help. If they're not helping you, call me. Groups like the Carlisle Clinic, a PA-led rural health clinic that was helped by the Northeastern Kentucky RIO as their extension center. And they went from paper to electronic. And they said, you know what, it was pretty good. They showed up, they helped us figure out what to use. They were actually on site. They helped some project management. You know, we're not an IT. We didn't go into this business to be IT specialists. And they helped. It was good. If you're already on an electronic health record, go for meaningful use. Not just because of the incentive payment, but because it's going to set you up to deliver higher quality, safer, more efficient, more coordinated, more patient-centered care. It really will. It really will. Folks like Peter and John, who we honored today. And once you've done that, or even before, pick something, anything, in the words of Atul Gawande. Pick something, measure it, make it better. Pick something, measure it, make it better, like we're doing with the Beacon communities at HealthBridge. What Scott Callahan's doing at Children's Healthcare with children's asthma. And when you've done all of that, if you're doing all of that already, you know what I ask of you? Brag on yourself a little. Tell others how you did it. What was easy? What was a clever little solution you found? Bear your scars. Share. Reach across. If you're one of those early adopters, if you've got it all figured out, be adjunct faculty. Adjunct because you don't get paid. But help the next person out. Join the Regional Extension Center. Not because you need the help, but because you want to teach others how to succeed where you succeeded. And finally, if you're anybody else if you're not a provider or a hospital, if you're a government official, if you're a health plan, if you're a purchaser, like Procter & Gamble and GE here, who've done so much. If you're a spouse or a family member, if you're a patient, help them. Help them do this. Help them change, and help them get to the point where we can deliver the kind of care we want to deliver. Thank you.